So my name's Rebecca Moor. I'm a Brisbane-based medical oncologist and I specialise in treating breast cancer. It's the majority of my practice. And I work at the Mater hospitals in Brisbane and at Springfield, and I also work at the Gold Coast University Hospital. And I also have a real interest in breast cancer research and clinical trials through the Medical Oncology Trials Group at Mater, and also Breast Cancer Trials Australia. So thank you for inviting me to talk. It's really nice to be able to come back to Rocky. I think the last time I was here for a placement in the base hospital for a period of about 3 months, but that was back in 2010, so it wasn't yesterday. But I think it's important that we can come up and meet face to face after COVID and put on these sort of forums and things as well. So this is just general advice, but and some of the medications that I'm going to be talking about haven't yet hit prime time for breast cancer. When I was trying to work out how I was going to fit this into 35 minutes, when I'm talking about 3 completely separate types of breast cancer, I thought I'd just mainly sort of start with those standard treatments and then what's new and emerging. But not new and emerging that's going to hit prime time in 5 to 10 years. Things that are going to happen within the next sort of 1 to 2 years and hopefully we'll have access to really soon. I'll also talk a little bit about clinical trials because they can be really important when you've got advanced breast cancer. And it is important to know how you can access those. So, even though you live in Rocky or Yeppoon or somewhere up here, you might be eligible for a trial that might be in Brisbane. I've had patients from Brisbane fly to Melbourne for clinical trials. I've got patients that I look after from sort of Bundaberg or Townsville who are on clinical trials with us at the Mater there. So there might be additional options, and then we'll try and leave sort of 10 minutes at the end to answer your questions. So, advanced breast cancer. We all know that breast cancer is common. 1 in 7 ladies will be diagnosed throughout their lifetime. And advanced breast cancer is breast cancer that's spread beyond the breast to other organs in the body. It can be classed as stage 4, secondary cancer, advanced breast cancer. 1,500 ladies are diagnosed with advanced breast cancer or diagnosed with metastatic breast cancer in Australia every single year. And this year, 3,200 ladies will die from metastatic breast cancer. So sometimes ladies feel like it's sort of a little bit forgotten. In Breast Cancer Awareness Month, it's all about sort of, your surveillance and things like that. But I think it's important that, we're letting you know what's new and exciting and what's happening. So advanced breast cancer might be a recurrence from an earlier breast cancer, and we heard Tracy talk about her experience earlier this morning. Or it might be the first diagnosis of someone's breast cancer. So the first time they get diagnosed, they're actually found to have stage 4 disease, which can be very distressing. So we're really talking about this top stair of sort of the breast cancer spectrum. Symptoms from breast cancer, it does depend on the type of breast cancer that you've got. So the most common type of breast cancer is invasive ductal carcinoma. So sometimes that's called IDC or invasive carcinoma NST. That's what the pathologist might write on the pathology form or report. And that's about 70 to 80% of breast cancer in Australia. Typical sites for this cancer to come back or to spread to is the bone. So in 65% of ladies, that's the bones are involved. Lymph nodes, liver, lung, and especially in HER2 positive and triple negative breast cancer, it can move to the brain as well. And symptoms really depend on what area of the body is involved. So with bone involvement, it tends to be pain, or sometimes people can even get fractures. With lung, it can be breathlessness or a cough. With the liver, it can be abdominal pain, or with brain, sort of headaches and nausea. So every lady with metastatic breast cancer is different, and some people it's even found as an incidental finding. So they've got a scan for some completely separate reason, and we find that the breast cancers come back. Now, I will just mention lobular carcinoma, or ILC. This is a less common cause of breast cancer. It's about 10 to 15%. And why it's important to sort of mention is that it tends to be a breast cancer that comes to different areas in the body. So this is a bit trickier. It tends to like sort of mucosal areas, so it can go to the bowel, it can go to the lining of the stomach, it can go to the bladder, it can go to the gynecological organs, so the ovaries and uterus, and it can go to bone. So it just behaves a little bit differently, but generally this lobular breast cancer is very highly ER positive, so in over 95% of cases it's hormone positive breast cancer. Now, breast cancer subtypes, and you all might know a lot about this already. That diagram, can you see my arrow? You can't see my arrow. Is looking at the lobules and the ducts of the breast. So it's sort of what cells these cancers have arisen in to start with. But it's also because they keep some of their features from where they started. So it can affect their behaviour and it can affect the treatment a little bit as well. Now, 2 in 3 ladies with advanced breast cancer are diagnosed with hormone receptor positive breast cancer, so it's by far our most common. 1 in 5 will have HER2 overexpression or HER2 positive breast cancer, and that can either be hormone positive or hormone negative in association with that HER2. And 10 to 20% of all breast cancers are negative for that estrogen, progesterone and HER2, and that's what we call triple negative breast cancer. And the treatment that I do very much depends on that type of the breast cancer. So the aims of treatment in advanced breast cancer are very different from those in early stage setting. We're really aiming to try and control the cancer, trying to get shrinkage and improve the length of life. But while we're doing that, also improve quality of life and minimise any symptoms from the cancer. But in most cases with stage 4 breast cancer, ladies won't be cured and they will be on some kind of treatment for the rest of their life. That treatment, if you're thinking about potentially years of being on therapy, we need to balance the chance of or decreasing the risk of progression and dying from breast cancer, but also balancing the side effects of the treatment and the inconvenience of the treatment. So sometimes thinking about our oral therapies, which can save people having to come into the day unit like 3 times a month. Or sometimes, thinking about medications and treatments where you're not going to get hair loss over, treatments where you do lose your hair. So there's lots of things we can do. In terms of what our standard is in Australia at the moment, in 2022, so it's different for all of those subtypes. So hormone receptor positive, HER2 negative breast cancer, first line treatment is with an aromatase inhibitor, which is an oral medication, or occasionally fulvestrant, which is an injection. So they're hormone blocking treatments plus a CDK4/6 inhibitor, and we've got 3 of these on the market in Australia. So we've got palbociclib, ribociclib and abemaciclib, and they're all the same type of medications. They all work roughly in the same way. In ladies, if they're premenopausal, so we can give these treatments, we'll usually add in Zoladex to shut the ovaries off, to stop the ovaries from cycling, so that we can use an AI. And those treatments have sort of revolutionised ER positive breast cancer, and we've been around in Australia since about 2017, and earlier than that on clinical trials. So HER2 positive breast cancer treatment will usually start with a taxane chemotherapy, so paclitaxel or docetaxel, plus HER2 targeted therapy with 2 IV antibody treatments, trastuzumab and pertuzumab, so Herceptin and Perjeta. And then we would usually, after a sort of an initial period using the chemotherapy, we'd usually stop it after sort of 6 cycles and then keep on those antibody therapies by themselves. At this stage, we'd also add in endocrine therapy if they're hormone receptor positive. And some ladies continue on those antibody treatments for many years and do very well before we even have to think about second line treatment. In triple negative breast cancer, so about 15% of ladies, then our mainstay of treatment is chemotherapy, and that choice really depends on their previous treatment, so whether they've got chemotherapy in the adjuvant or early stage setting, the time between their initial diagnosis and recurring, or the extent of their disease. But it may be things like Abraxane, capecitabine, lots of different options there. In terms of, this is one of those medications for ER positive breast cancer, so these are the CDK4/6 inhibitors, and they work by, they're reversible oral medications. They work by exploiting the cell cycle machinery, so they actually block the cell from going through its process where it's growing and dividing. And so the cells can't move on in their cycle to grow, and so they get stuck, and if they get stuck long enough, then often they'll end up dying. And we get cancer shrinkage that way. We use them in combination with endocrine therapy, and they work very, very well together. There's 3 different types, which I mentioned before. They all significantly prolong progression-free survival, so that's the time where the cancer is stable until the cancer grows and we need to think about doing something else. They all prolong the time until we need to think about chemotherapy in these patients. And ribociclib and abemaciclib significantly prolong overall survival as well. Palbociclib, the trials just need to go on for a little bit longer, and we might find that becomes significant in time.
Is there other ones that are coming out, those 3? I've tried all those 3, and one attacks my kidneys, one attacks my liver, and the other attacks both. So I can't use any of those ones.
There are new ones in, so there's medications coming out of China that are the same sort of mechanism, but they're only on clinical trial at the moment. So often if we've sort of tried all of them, then we go back to the endocrine therapies. But
if those 3 did that with me, is there a chance that the new ones would do exactly the same thing?
Potentially, but I mean the side effects are a little bit different, which will be my next slide as well. So in terms of the response rate, that's similar across all of them. They all work about this as well as each other. The abemaciclib, we just got the survival data on that in ESMO, so just in September. And the survival for ER positive breast cancer is well past 5 years, and that's the average. So I will always tell ladies when they come and see me and they ask that question about what's my prognosis, that I know the average, but patients aren't average. So, you know, that's what 50% of patients will get to. But we have to keep in mind that 50% of patients will do significantly better than that. And I still have ladies who are on these particular clinical trials and still going on their medications now, and we're 6 years down the track. So they've sort of well and truly blown those statistics out of the water. Now, as we were mentioning, those side effects of these medications, they do differ between them. So palbociclib and ribociclib, they are given for 3 weeks and then you have 1 week break. They are more likely to cause neutropenia, which is a low white cell count, but often that doesn't tend to be clinically significant. So ladies don't tend to land in hospital with infections. It's just something that we monitor, and occasionally we need to alter the dose a little bit. With ribociclib, it can affect the liver, and it can also affect the electrical activity in the heart. So often we need to monitor with ECGs to start with. Or traces of the heart, and then that will happen for sort of the first 2 months, and then if nothing has happened by then, it's okay. Abemaciclib is less commonly used, but if the neutropenia is a real problem, then sometimes I will move across to abemaciclib. It's much more likely to cause diarrhoea, and that diarrhoea can be really significant. So, you know, 8 out of 10 ladies on this medication can get it. So it involves lots of education to try and get on top of it and to try and prevent it from happening. You're nodding like you know exactly what that's like. But there are ways to manage it, and that's given every day, so it's continuous where the other ones have that scheduled break. And they're used with an AI, which is continuous for the 4 weeks. This is just some information about the studies themselves, but that's lots of things. In terms of our new emerging treatments, this is a class of treatment that's really, really exciting. So antibody drug conjugates, and this is a newer way of targeting cancer rather than our standard chemotherapy that we used to use. It's really exciting, and they can be really, really effective with less side effects than conventional chemotherapy. So examples of these types of medications can be TDM1 or Kadcyla or trastuzumab emtansine, which we have been using for many, many years in HER2 positive breast cancer. One new that hopefully will be hitting prime time within hopefully the next 12 months is trastuzumab deruxtecan or TDXD or Enhertu. And this has also got great results in HER2 positive advanced breast cancer. But there's also some really promising results in what we call HER2 low breast cancer, and that's in patients that we previously characterised as triple negative or ER positive. And I'll get to some more information about that in a second. And then another medication is called sacituzumab govitecan. They don't make any of these easy to say. It gets shortened to SG or Trodelvy. And that's got some really good evidence in the triple negative breast cancer setting. And that's already just been listed on the PBS this year, so this is a medication we're already using. In terms of, so this is TDXD or trastuzumab deruxtecan. It has the same antibody as trastuzumab or Herceptin as the main component of it, but it's also got these little sort of dots that you can see on there as well, which is chemotherapy molecules that are linked to this antibody. So what it does is that antibody hones in on the receptor on the cell surface of the cancer. So in this case, it's HER2. It gets taken into the cell, and then that chemotherapy gets released. So the chemotherapy is going directly to the cancer cells. With this one, occasionally a little bit leaks out, so it can kill cancer cells that are in the close vicinity to it. And then down the bottom there, we're just comparing TDM1 and TDXD because they're both used, or there's been some studies looking at this in the second line. But this is a really exciting medication. And on that waterfall plot, or on the other side there, that's just showing one of the early phase clinical trials, which showed that 62% of ladies got cancer shrinkage in HER2 positive breast cancer with this medication. And they were ladies that had been heavily treated, so they'd had breast cancer for a number of years, they'd already gone through a number of lines of treatment, and this drug worked really, really well. So then they did a big phase 3 trial with thousands of patients, looking at this compared to our standard second line treatment in HER2 positive breast cancer, TDM1. And what it showed on the graph down the bottom there is that the patients who were treated with TDXD, which is that blue line, it's much higher than the bottom line. So they're doing much, much better. So at the 1 year mark, with this new medication, 76% of ladies were stable and still on treatment, compared with only about 30% on TDM1, which was our other sort of previous standard second line. And the response rate in the second line was even higher, so 8 out of 10 ladies with HER2 positive breast cancer got cancer shrinkage with this medication. So it's a lot more effective, and that's why we're excited that this is going to be coming to Australia hopefully soon. So we should have this within the next year or two. Now, all of our treatments have potential side effects. I tell ladies that everything I do can give side effects. But these are usually manageable. It can cause some nausea. It does cause hair loss, and much more so than TDM1. And one of the new things that we found with this is sometimes it can cause an inflammation in the lungs. So we just do have to be a little bit aware of patients who are developing cough or breathlessness. And I have a fairly low threshold to do a scan of the chest in those ladies, because sometimes it might show that they've got inflammation that we need to think about using steroids for. If it's really bad, then we do have to stop this medication. But that was only at about sort of 1% of patients that they had to stop. In terms of, we're also using this medication now in what we call HER2 low disease. So this is a completely new classification of HER2. And whereas it's a lower level of HER2 positivity. So usually when the pathologists are doing the staining for HER2, they give it a grade from grade 0 or IHC 0 to IHC 3. And previously only grade IHC 3 was classed as HER2 positive, and so therefore we used those medications that are targeting that HER2 receptor. But what we've found is that these newer medications can actually be helpful in patients with IHC class 1 and class 2. So I'm going back and looking at all my patients' original biopsies to try and work out who might benefit from this. And so 60% of HER2 negative metastatic breast cancers express low levels of HER2, and we can use these newer medications in those ladies. And there's data that has come out for this new medication, TDXD. So this is in ladies with HER2 low advanced breast cancer, and they could be previously triple negative or ER positive. And again, this is comparing in sort of later on down the track. So once ladies with ER positive disease have become refractory to all of those hormone blocking treatments, then sometimes we think about chemotherapy in those patients. And this is comparing this new medication, TDXD, to their oncologist's sort of choice of chemotherapy drugs. And again, that blue line, which is our treatment, is doing much, much better than the grey line below. So it allowed ladies to be stable on the medication for nearly another 5 months. And it also resulted in ladies living longer. So we had a benefit of 6.6 months extra life with this medication added in compared to our previous sort of lines of chemotherapy. So it's really another good medication to have in our arsenal, and it will be helpful for a lot of ladies down the track. So this is just trying to illustrate that this new class of HER2 low a little bit better. Just in the table up the top there, we did see sort of response or shrinkage with this medication in 1 in 2 ladies. And this is sort of in the advanced setting, so they have had lots of treatments in the past, which is really good. And we're finding that they're able to get benefit from this medication for a long period of time. So in that pie chart there, that's looking at HER2 positive breast cancer is there in the orange. So they're the ones that we would typically think would benefit from these HER2 targeted treatments. But another 31% of cancers were beneficial. So including 1/3 of all ladies with triple negative breast cancer had HER2 low disease. And 2/3 of ladies with ER positive breast cancer had HER2 low. So this is going to be helpful in a lot of ladies. However, unfortunately, still 1/3 have IHC of 0 and probably aren't going to get a benefit. But this isn't yet funded in Australia, but hopefully it's coming in the not too distant future.
So can I ask
Yep.
a question? Have they got to the stage of compassionate grants yet for that?
Not just yet. There's still ongoing clinical trials, so they are moving it into sort of the first line treatment as well. I haven't heard any news of compassionate access just yet, but hopefully, we'll start to see it soon. I wouldn't be surprised if the drug companies do come around to compassionate access. For those of you who aren't aware, sometimes in the space between getting the results of something becoming a new standard treatment that we should be giving to patients if we had it available, and the lag time between that happening and the government putting it on the PBS is sometimes up to 2 years. So sometimes these companies that are making these drugs will give us access by what we call a compassionate program, where they'll actually, if your oncologist asks for it and registers on the program, they'll give the medication for free. And we had lots and lots of ladies who are on programs like this for those CDK4/6 inhibitors in 2017, 2018. And we know we got them access to these medications a couple of years before they got on the PBS. So it is a good thing to know about. Sometimes they won't, they'll have programs where you can choose to fund them, but a lot of times these medications are really expensive, so that's not an option for everyone. Or sometimes we can get access on clinical trial as well, so if you fit certain criteria, that we might be able to get it for patients. In terms of also looking at triple negative breast cancer, this medication, sacituzumab govitecan, or SG, is another antibody drug conjugate, and it's targeting TROP2, which is a protein that's expressed on all subtypes of breast cancer, but strongly on triple negative breast cancer. And it's again has a linked chemotherapy drug or a sort of payload, so it takes that chemotherapy right to those breast cancer cells. So we get less systemic side effects from the chemotherapy. It lets us give a bigger dose of sort of targeted chemotherapy to those breast cancer cells with slightly less side effects than if we were giving it sort of basically through an IV. And so this uses a chemotherapy drug which is very similar to another medication called irinotecan that we use commonly in GI cancers, and it's got similar side effects to what we'd see in that setting. So this is a big study that was done in second line or greater triple negative breast cancer, and again it's comparing against the oncologist's choice of chemotherapy. So that is comparing against one of 4 different types of chemotherapy that the oncologist felt was the next best choice. And we found that in these patients who had had lots of treatment before, there was really promising response. So it prolonged the amount of time that they were able to stay on treatment, and it also led to patients living longer. So the response rate for standard chemotherapy was about 5% of patients getting shrinkage, so that's not really very much. And with this new medication, it was 35%, so that's pretty impressive. And sorry, I've made my slide too small there, but there were a lot of ladies that were remaining on treatment, past that 12-month mark, which is, in triple negative breast cancer, is fantastic. Often we only get a couple of months out of each line of chemotherapy that we're using. So for someone to be on this treatment for 12 months is pretty amazing. Side effects, diarrhea, neutropenia. We do give pre-treatment medications to try and limit this, and there is a bit of nausea there as well. So they're just the things that we watch out for, and sometimes we need medications to try and help with those. In terms of immunotherapy, now this is another new class of cancer treatment, and we hear lots about it in the press for different types of cancers, so things like melanoma, lung cancer. It works really well even if we just give it by itself. That's not the case in breast cancer. We need to give it with chemotherapy to get any kind of response. So these are drugs that stimulate people's own immune systems to attack and kill cancer cells. And the main medications in breast cancer are drugs called pembrolizumab or Keytruda and atezolizumab or Tecentriq. And they're really in a certain cohort of triple negative breast cancer patients that have high levels of PD-L1 or this specific marker that's in their cancer. So it's PD-L1 positive cancer that are more likely to respond to immunotherapy, and that's about 40% of triple negative breast cancers. So it's not something that we currently test for on pathology reports, but most pathologists can do that marker if we're thinking about using these treatments. And these are the two sort of big trials looking at these treatments, and they're both first line as first treatment in triple negative breast cancer, and they have done better than chemotherapy itself. I guess why we're so excited about these medications is that immunotherapy in other settings, even in advanced disease, sometimes we can even see cures with immunotherapy where the cancer is controlled for a really, really long time. I've had patients with melanoma and lung cancer with stage 4 disease that their cancer has shrunk away, and I've been able to discharge after 5 years saying that I think they're probably cured. So if we can get to anything like those results in breast cancer, that'd be revolutionary. So again, I think based on the clinical trial with pembrolizumab, I think that's probably going to be funded, but it's not yet funded in Australia just yet. Atezolizumab, I think, probably won't get funded, just in terms of those curves sort of come together in the end, so the company's not sort of pushing for that quite so much anymore. So, but pembrolizumab may be something that we start to see. Now, you had a question? Jump in.
Is there any contraindications for immunotherapy?
There certainly is. So because it's ramping up people's immune system, certain types of autoimmune diseases can be flared up with this. So in people with poorly controlled, like Crohn's disease or inflammatory bowel disease, then sometimes that's a reason why I wouldn't think of giving it. These trials are done with chemotherapy, so patients have to be well enough to have a really aggressive course of treatment, and then the chemotherapy usually drops out and we continue the immunotherapy by itself. In ILD or sort of chronic lung issues can be a contraindication as well. Anyone that's had any organ transplants, we usually wouldn't use it. But I'm nearly coming to the end, so we'll have plenty of time for questions. But it does cause a whole range of different side effects. So it's not without side effects, it's just different side effects to chemotherapy. So these drugs can cause inflammation of basically any organ in the body, from the skin to the brain to the lungs to the colon. The biggest side effect from immunotherapy is about half of patients get fatigue, but compared to chemotherapy, that's pretty good. But also we can get these autoimmune symptoms as well. So most commonly we can see hyper or hypothyroid, so the thyroid gland going over or underactive. We can usually manage that with sort of hormone supplementation if the thyroid does go underactive. And sometimes these side effects can be severe. So in 1 in 10 ladies might get a really severe side effect from their immunotherapy. And so it can cause inflammation of the lungs, so we can get shortness of breath or cough. It can cause inflammation of the liver, making the liver tests go up or abnormal, or even giving people jaundice. It can cause inflammation of the colon, giving people diarrhoea. It can give really bad inflammation of the skin. But most of those side effects will settle down with steroid-type medications to dampen down that immune response. So, I think it's something that we will be beginning to start to use. We can get it self-funding, but it is incredibly expensive. So there is a co-pay program for Keytruda. It costs in the region of $60,000. So I don't know anyone that's got that kind of financial resources. So really until we start to get this on the PBS is when we're going to be able to use it. It is very expensive, but potentially it might have a place in sometimes types of triple negative breast cancer. It hasn't really shown much promise in ER positive breast cancer or HER2 positive breast cancer. So I've sort of shown a lot of data from big clinical trials. And what I'm talking about when I say clinical trials is that these are carefully designed studies that aim to find out if new treatments are more effective than those that are currently accepted as our standard of care. So this is sort of our research in action, and each of those graphs would have had a couple of thousand of patients on them that have been randomised, so got a 1 in 2 chance of getting the new medication versus sort of what we would standardly use. And they aim to look at how well treatments work to control or cure cancer, whether they have side effects, whether they're safe, what kind of symptoms they lead to, and whether they can improve someone's quality of life. So every new breast cancer treatment that gets listed on the PBS has to go through this really rigorous process of getting tested. before it's made widely available. And so this is one of the sort of big breast cancer trials groups. So it's Breast Cancer Trials Australia, and they've got lots of breast cancer trials that they sort of help fund and run. Clinicaltrial.com is another way that you can find clinical trials as well. And in some of those settings, they might have had early trials that proved that medication worked in a certain type of cancer. And then in those big phase 3 trials, that's where sometimes we already know that it's really promising, it's got good data behind it, but sometimes we can get patients onto those medications. So at MARTA, we've got clinical trials with the Destiny trials, which is the TDXD in certain settings as well. So, you know, and being in Rockhampton doesn't mean that you can't get onto a clinical trial. I've got patients that travel from all around Queensland to be on trials. One of the good things that came out of COVID, if there was anything, is that we're doing more via telemedicine now. Townsville runs some trials, tele-trials, so they can be linked with people sort of more regionally. Sometimes the people that are running the trials, so the companies will actually pay for patients to fly down, stay in Brisbane for their treatment and be able to go back. So it is something to think about. We'd usually think about it when someone first gets diagnosed as their first treatment, or if the treatment that they're on stops working and we're thinking about it as our next sort of go-to. I'm getting the hurry up. It is a really exciting time for metastatic breast cancer. There are many new treatments and effective therapies that are coming, and they're coming soon. So we are trying to move towards more personalised treatments. There's no one-stop shop for advanced breast cancer anymore. It very much depends on your particular tumour, all of those markers. Clinical trials might be an option even if you're not in Brisbane.